Good morning everybody, and today what we're going to discuss is cardiovascular disease and diabetes, and this is the fifth and final lecture in your diabetes lecture set. So let's get going. Right, you know that there's an increased risk of cardiovascular disease in those people living with diabetes, and it's estimated that roughly between diabetics are 2 to 5 times more likely to either have or die from cardiovascular disease compared to non-diabetics. Diabetes is considered a coronary artery disease risk equivalent in some circumstances and in certain calculators. And of course, patients with diabetes are 2 times more likely to have a stroke. So, essentially what we're going to be discussing today are the atherosclerotic cardiovascular diseases, or the macrovascular complications, and more than just discussing them, rather, which you've already done before, how to treat an MI, how to treat a stroke, how to manage peripheral artery disease. What we're going to rather spend time on is what do we do in a diabetic patient to prevent cardiovascular disease. And in order to do that, what we need to look at is the different cardiovascular risk factors. And these cardiovascular risk factors include cigarette smoking, dyslipidemia, obesity, hypertension, and of course their blood glucose levels. So let's start off by discussing cigarette smoking. We know, for example, that encouraging all patients to stop smoking is very important, and that smoking also increases the risk of coronary artery disease and peripheral artery disease in diabetic patients. We need to discuss with patients methods to achieve smoking cessation, and of course we must remember that pharmacotherapy may be required, and we must take into account Prochaska's model of change, whether they are in the pre-contemplation phase, contemplation phase, etc. Are they willing to move forward? Are they not yet ready to actually quit smoking? We need to take all this into account when we are actually speaking to the patient. And of course, we must assess their smoking using the 5 A's. So what are the 5 A's? The first A is to ask. So we systematically inquire about smoking status at every opportunity that we get. In other words, every time we see the patient, we ask them, do you smoke? And if they say yes, you ask them the next question, right? Don't you think it's time you should quit? And that's the second A, advice. Unequivocally urge all smokers to quit. Then the third A is determine the person's degree of addiction and readiness to quit. So when you say, don't you think it's time you should quit, they'll either give you some kind of an answer like, I'm not yet ready, or I don't really want to quit, or whatever the scenario may be. And that's always fine. That's fine. Remember that you are not there to stand in judgment for the person, right? And rather, what you should rather tell them is stuff like, okay, well, when you think you're ready, or when you think that you want to quit, come back and speak to me, and we'll discuss on the way forward, alright? And then if they say, yes, I'm ready to quit, you then move on to the next A, which is assist. And you agree on a smoking cessation strategy, right? Including setting a quit date, behavioral changes, and if necessary, pharmacological support as well. And then you move on to the 5th A, which is arrange. You arrange a schedule to follow up with the patient so that you and the patient can then discuss the way forward, or what has happened in the past couple of days, how they have gone about their smoking cessation program, what has worked, what hasn't worked, what they think can be done better, what you think can be done better based on the scenario. Right, now there are a number of ways in which smoking cessation can take place. There's both pharmacological and non-pharmacological means, right? The pharmacological means we're going to discuss in significant detail, and the non-pharmacological means we will discuss a little bit about. Of course, cognitive behavioral therapy everybody's heard of, right? So I'm not going to spend time on that so much. Rather, we'll spend a little bit of time on START and structured education, right? And that's START itself is actually an acronym, and it's an acronym for set a date, tell everyone, The A then stands for anticipating any problems. The R stands for removing all tobacco from the household. And of course, the T stands for take action. So it's set a date, tell everyone, right? Obviously, remove all tobacco products from the house, and of course, arrange everything, and then lastly, take action. Alright, structured education we're going to discuss in a bit more detail later on, so we're not going to go through that right now. Then we're going to look specifically at the Desmond study. For now, let's discuss nicotine replacement therapy, then bupropion, then varenicline, and then the combination of them together. Right. In nicotine replacement therapy in South Africa especially, it's available as gum and patches. The gum, or the 4 mg gum, is commonly used for patients who smoke more than or equal to 25 cigarettes a day. The 2 mg gum is for people who use less than 25 cigarettes a day. Monotherapy requires a fixed dosing schedule, and chewing like normal gum will lead to GI upset. And I think that this is something that's very important that you need to point out to all your patients who are actually going to use the nicotine replacement gum. It's worth noting that most of the nicotine in the gum is gone within 30 minutes. In addition to the specific counseling about the patient not chewing about chewing the gum, in the method in which they chew the gum is to actually chew the gum till the peppery taste appears. Then after that, to park the gum against the side of the mouth so that there is buccal absorption of the actual nicotine gum, and then to remind the patient that they should not eat or drink 15 minutes before or while using the gum, right? And they shouldn't eat or drink substances like coffee, soft drink, juices, etc., as these acidic beverages can lower the pH of the saliva and reduce the efficacy of the buccal absorption. Right, now patches available in the 21 mg per day, the 14 mg per day, and the 7 mg per day. Step 1 is the 21 milligrams, step 2 is the 14 milligram, and step 3 is the 7 milligram. Smoking, if a person smokes less than or equal to 10 cigarettes a day, you then start them off on the 14 milligram patches, and that you do for roughly 2 weeks before you move on to the 7 milligram patches after that for another 2 weeks. If the person is smoking more than 10 cigarettes a day, you start them at step 1. So there at step 1, what you're going to do is you're going to go 21 milligrams of a patch per day for approximately 6 weeks, then 14 milligram patches per day for 2 weeks, and then 7 milligram patches per day but for 2 weeks. And unfortunately, the adverse effects of using the patch is that it can cause skin irritation and tingling, for which you can prescribe hydrocortisone cream to be applied to the area where the patch was normally applied, and to remind the patient to apply the patch to different areas of the body. Bupropion is a non-nicotine oral tablet which is effective in smoking cessation. Now, you may notice that it's actually a dopamine and norepinephrine reuptake inhibitor. Alright, and the starting dose for bupropion is 150 milligrams of the extended release formulation daily for 3 days, and then to move up to 150 milligrams twice a day for 7 to 12 weeks. The prescription may be extended for beyond 12 weeks, and the quit date is usually 1 to 2 weeks after the person has actually started taking the medicine, and that is because bupropion takes at least 1 week to reach steady state concentration. If no cessation occurs after 7 days, you should consider discontinuing the drug. It is contraindicated in patients with a history of seizures, anorexia, or bulimia. And the drug is, of course, it has multiple drug interactions and is metabolized by cytochrome 2b6. It not only lowers the seizure threshold, which increases the risk of having epileptic fits, but it also causes tremors and insomnia. And of course, the adverse effects such as tremors and insomnia may be avoided by slowly titrating up the dose of the drug as described here, starting at 150 milligrams extended release for the first 3 days and then moving on to 150 milligrams twice a day for 7 to 12 weeks. Now, one of the things that I do like to test, and I'm sure you've noticed this already, is I do like to test dosages, and I also like to test the way in which the medicine is given. I'm not so interested in, of course, what the mechanism of action is. I may ask you some things related to how to reduce adverse effects if that is, of course, necessary. Right. Varenicline is a partial nicotine receptor agonist. So it's a partial agonist at the alpha 4 beta 2 neuronal nicotinic acetylcholine receptor subunit, and it also stimulates the release of dopamine and decreases nicotine withdrawal and craving. From day 1 to 3 you start at 0.5 milligrams a day. Then from day 4 to 7 you go at 0.5 milligrams twice a day, and from day 7 onwards you go with 1 milligram twice a day, and the quit date is usually 1 to 2 weeks after beginning the varenicline. Now, varenicline usually requires prescription for roughly 12 to 24 weeks. It does not lower the seizure threshold in any way, so it is something that you can use in patients with epilepsy. However, there are some serious adverse effects associated with it, such as a dose increase in suicidal ideation. It also causes agitation, hostility, depression, and worsening of pre-existing psychiatric conditions. So a psychiatric exam is extremely important. Some of the milder adverse effects includes nausea, headache, insomnia, abnormal dreams, which is a nice way of saying people have nightmares, and of course dyspepsia as well. Now, the best choice. Now, there's a lack of evidence that suggests one protocol is better than another, and there's no well-accepted algorithm that exists in terms of smoking cessation. So therapy for smoking cessation must be individualized and must be combined with structured education. Now, the Desmond trial, which is something that used structured education primarily, so it was structured education in newly diagnosed type 2 diabetics, right, found that structured education increased the chances of somebody cessating smoking or stopping smoking compared to the placebo at 12 months. But at the 3-year follow-up, this effect was lost. In other words, what they're saying is that structured education can only work in the short term. It doesn't necessarily work in the long term for the person to actually break their habit. And for heavy users or highly dependent users, you probably need a multiple set of strategies, or patients who have diabetes, for example. And in that way, what you would then consider is using bupropion with, as needed, nicotine replacement therapy, either in the form of gum or patches, preferably in the form of gum, and varenicline in the dosing schedule like we've discussed before, which I think is important for you to know. Of course, then varenicline with, as needed, nicotine replacement therapy gum. Alright. And with all of these, it's worth considering combining them with structured education given the information that we've gotten from the Desmond trial, because it may help more in the shorter term, and the shorter term, particularly when you are using nicotine replacement therapy and when you're using bupropion and varenicline, is actually quite important. Right, let's discuss the next one, which is dyslipidemia. We know that most frequently in type 2 diabetics, you have an increase in triglycerides and a decrease in HDL, and LDL-C is not markedly raised. This is something that we've already discussed in steps. But in diabetics specifically, their LDL tends to be a lot more dense, a lot lower in density, but more atherogenic. right? And it being more atherogenic means that it is more likely to cause atherosclerotic cardiovascular disease. It's smaller and it's more atherogenic. Thus, the LDL-C that you get when you actually look at the LDL-C on a lipogram is actually misleading. For type 1 diabetic patients, if they're poorly controlled, you'll find that they have elevated triglycerides and total cholesterol. If they're well controlled, their cholesterol levels will be similar to that of non-diabetic patients. So, when and how do we measure cholesterol levels in diabetic patients? Well, we measure the serum lipid levels at the first visit, and if elevated, we retest. And how do we retest? We retest actually by asking the patient to fast, alright? And we need them to fast for a minimum of 12 hours, and then we obviously will retest them, right? If measuring LDL-C directly via laboratory methods, of course, there's no need to fast. If the person has marked levels of triglycerides, then we definitely need to do a fasting test, right? And if the fasting lipogram is then normal, we measure annually. If the fasting lipogram is abnormal, we then measure again in 3 months. And we must exclude causes of secondary dyslipidemia. So we must exclude the causes that include hypothyroidism, renal disease, medications such as glucocorticosteroids, retinoic acid and its derivatives, protease inhibitors, estrogen, drugs like sirolimus, for example, and even alcohol abuse. All of these must be excluded when we are taking into account the person's lipid profile. Of course, the goals we've already discussed before, and it's important for you to know. Ideally, we're looking for a total cholesterol of less than 4.5 millimoles, an HDL of more than 1 in men, an HDL of more than 1.2 in women, triglycerides of less than 1.7, and LDL-C of less than 1.8. And how do we achieve these goals? Well, we achieve these goals in one of two ways, either through most commonly in diabetics, it's a combination, right? In other patients, it can be one or the other. But in diabetics, it's generally a combination of lifestyle modification and pharmacotherapy. Now, the lifestyle modification includes dietary restrictions in line with current guidelines for diabetic dyslipidemia. In patients with severe hypertriglyceridemia, that is 10 to 15 millimoles per liter or greater, they will respond to triglyceride restrictions, right? And particularly as well restrictions in terms of the types of carbohydrates that they eat. All diabetics should receive healthy lifestyle advice regarding their diet, and calorie restriction may be required to produce weight loss if the person is overweight. And we know, for example, that even a 5 to 10% weight loss from their baseline will reduce their blood glucose and their cholesterol levels. It may not reduce their risk of cardiovascular disease, but it will definitely reduce their blood glucose and their cholesterol levels, and will have a significant effect in terms of their triglyceride levels, right? And we know that glycemic control and triglyceride is linked. So the hypertriglyceridemia is linked. So the better their glycemic control is, the better their hypertriglyceridemia will actually, in fact, be managed. We know, for example, that there is limited evidence on the ideal amount of macronutrients in the diet of a patient with diabetes. The type of fat consumed is probably more important than the amount of fat in patients with severe hypertriglyceridemia. Additionally, Mediterranean diets, for example, are high in monounsaturated fatty acids and have actually shown to improve glycemic control and lipid parameters, which means they will actually control hypertriglyceridemia as well. Trans fats, of course, should be avoided because they have a proven negative effect on cardiovascular outcomes, while saturated fat intake should be limited to less than 7% of the patient's total calorie intake. Right? The consumption of oily fish should be encouraged. We should encourage this at least 2 to 3 times per week, and routine prescription of omega-3 supplements for either primary or secondary prevention of cardiovascular disease is not supported by randomized controlled trials. Additionally, omega-3 supplements, right, in high doses of 2 to 4 grams per day can moderately decrease triglyceride levels, but that comes with the added adverse effects of it increasing potentially your total cholesterol levels, which is not necessarily something you want to do. Right? Instead, you should try to reduce triglyceride levels using dietary modification first, and then if necessary you may have to consider other avenues like fibrates, particularly if the person has severe hypertriglyceridemia and is at risk for pancreatitis. Right, when it comes to fiber, the fiber content of the diet should be increased, aiming for an intake of roughly 14 grams per 1000 kilocalories consumed, and particularly now when it comes to alcohol consumption, in the presence of obesity or hypertriglyceridemia, alcohol should be avoided. Otherwise, alcohol should be restricted to maximally one standard drink per day in females and 2 standard drinks per day in males. Right? Poor metabolic control is a definite contributor to diabetic dyslipidemia, and it is important to ensure that glycemic control is adequate. Adequate glycemic control is particularly important in patients with severe hypertriglyceridemia, where it is a common secondary causative factor. Like I discussed before, I said glycemic control and hypertriglyceridemia are linked, and we know that they are linked, right? Therefore, good glycemic control will reduce hypertriglyceridemia. And in patients with severe hypertriglyceridemia and poorly controlled diabetes, initiation and intensification of insulin therapy should also be considered and should generally not be delayed. Right, the pharmacotherapy of dyslipidemia is about achieving the LDL-C goal in these patients, and of course this will lower the risk of primary and secondary outcomes, right? And in patients who are unable to achieve the LDL goal, we must consider either a high potency statin, right? Or alternatively, if they cannot take the highest potency statin, the highest potency statin that they can tolerate combined with ezetimibe, right? So if they cannot use the high potency statins, it's the highest potency statin that they can tolerate combined with ezetimibe, right? And of course, fibrates may be required in patients with persistent hypertriglyceridemia despite statin therapy, and specialist supervision is obviously required here. And there is no evidence for use of drugs that increase HDL-C or decrease triglycerides in preventing cardiovascular outcomes. And I think this is very important. So it's worth noting that fibrates don't in any way prevent cardiovascular outcomes, and the same is true for niacin, right? Fibrates are therefore there only for severe persistent hypertriglyceridemia, because you don't want the patient to develop pancreatitis. Right. Statin therapy should of course be added to lifestyle therapy regardless of the baseline lipid levels of all patients with type 2 diabetes if they have the following conditions. In other words, these are non-negotiables for statin therapy, right? That includes somebody who already has pre-existing cardiovascular disease. So here we're talking about secondary prevention of cardiovascular disease. In other words, someone who's already had a heart attack, a stroke, is having angina, is having peripheral artery disease as examples. In them, already statins must be used, regardless of what their baseline lipid levels are, because you want to reduce their lipid levels by approximately 50% from baseline. Additionally, in those patients who have chronic kidney disease and whose EGFR is less than 60 mL per minute per 1.73 square meters, as we know, Chronic kidney disease is already a cardiovascular risk factor. Diabetes is a cardiovascular risk factor. Combined, they are an extreme cardiovascular risk factor, and as a result of that, we must use statins. Additionally, statin therapy must be used in those who are older than 40 years of age or have had diabetes for longer than 10 years with one or more additional cardiovascular risk factor. In other words, there just needs to be one extra additional cardiovascular risk factor, and that includes, it can be, of course, dyslipidemia if that's the case, or hypertension, or smoking, or obesity, for example. Any one of those would be fine. We never use simvastatin 80 milligrams in newly diagnosed patients. It's because simvastatin 80 milligrams has the highest risk of rhabdomyolysis, right? And of course, it also causes the most amount of myalgia. Remember, a patient who is obviously suffering with myalgia or rhabdomyolysis, you want to maybe try rosuvastatin or pravastatin, because those ones are the water-soluble statins, right? But generally in your diabetics, you're going to go for your rosuvastatin if they suffer from myalgia. If they don't suffer from myalgia, you can of course go with your atorvastatin, because you want a high-potency statin. Statin treatment in type 2 diabetes has been shown to markedly reduce the risk of cardiovascular events and improve survival. And of course, statins are safe to use in renal failure, provided that they don't actually cause rhabdomyolysis, which is why when you prescribe statin therapy, you must of course look at their creatinine kinase levels. Right, now generally the statin goal, as we've discussed before, for all patients who are diabetic is to have an LDL-C of less than 1.8 millimoles per liter. It then depends what their starting LDL or their baseline LDL is, and based on their baseline LDL, we'll then pick an appropriate statin therapy for them to use, and we'll titrate up if that is actually necessary. Now, for regarding prescribing statins, I will of course provide you with the table. I won't of course tell you what the LDL-C goal is, because that's something of course you need to know in order to be able to prescribe the statin therapy. Alright, the efficacy of the statins. We know that the statins are of course able to reduce coronary artery disease, and as well they are also able to reduce other cardiac events, and therefore overall they reduce all cardiac events. And you can see here that the 95% confidence intervals for each one of these do not pass 1, and of course there is a relative risk reduction here of roughly between 14 and 16%. They also reduce any vascular events by roughly 14% with a significant 95% confidence interval, and they reduce any vascular events. They don't reduce any vascular events, as you can see here, because the 95% confidence interval passes 1. But overall, any deaths are actually reduced by the use of statin therapy by roughly 10%. So there's a relative risk reduction of approximately 10% with a 95% confidence interval, which doesn't pass through 1, making the result significant. Alright. Now, other agents used in the management of dyslipidemia include the fibrates such as bezafibrate, fenofibrate, and gemfibrozole. Gemfibrozole we hardly ever use. Instead, we would rather use bezafibrate and fenofibrate. And this is, I think, particularly true if we're going to combine them with statins. If we're going to combine with statins, we'll generally want to either use bezafibrate or fenofibrate, and we would hardly ever want to use gemfibrozole, because it increases the risk of myalgia and rhabdomyolysis when combined with statin therapy, which is why specialist consultation is advised before initiating statins and fibrate combinations. Remember that fibrates are indicated for severe hypertriglyceridemia, and they are indicated to reduce the risk of pancreatitis. Right, now ezetimibe. Ezetimibe reduces LDL-C by approximately 15 to 20%, and it's combined with statins to reduce the LDL-C to the desired goal. And we know that ezetimibe works because of the Improve It trial, right? The Improve It trial has suggested to us that, of course, patients who combine the maximum tolerated statin dose with ezetimibe of 10 milligrams per day, so the dose is 10 milligrams daily, right? We know that they actually reduce their cardiovascular events, right? Which is why we combine statins with ezetimibe. Now, PCSK9 inhibitors include evolocumab and alirocumab, right? And these are monoclonal antibodies. They are agents that will play a role probably in the future, and they will particularly be used for those patients who are intolerant to high doses of statin therapy, and then will require the use of PCSK9 inhibitors to reduce the LDL-C to goal. Now, the PCSK9 inhibitors can reduce LDL-C quite markedly, right? And therefore sometimes we would use them in the maximum tolerated, then you combine them with the maximum tolerated statins. For now, we can clearly see based on the studies that have been published that there is a clear role for these agents in secondary prevention of cardiovascular disease, particularly alirocumab, right? Which has proven cardiovascular risk reductions, but only in secondary prevention of cardiovascular disease when combined with the maximum tolerated statin dose that a patient can take. So, a reminder that type 2 diabetes is considered a coronary artery disease risk equivalent, and dyslipidemia as well as other cardiovascular risk factors should be looked at aggressively in every patient. In most diabetic patients or subjects, the risk is due to LDL-C, right? Causing their dyslipidemia, but essentially most of them will actually just have high total cholesterol and hypertriglyceride levels. And it's worth noting that atherosclerotic cardiovascular disease is more linked to the LDL-C levels, whereas the hypertriglyceride levels actually cause their pancreatitis. And it's worth noting that severe hypertriglyceridemia, that is a triglyceride level of greater than or equal to 10 to 15 millimoles per liter, right, will require intervention of diet and diabetes control to, of course, avoid pancreatitis. Lowering LDL cholesterol with statin therapy reduces major cardiovascular events, and of course statins are considered the first line agent to reduce LDL-C levels, and of course we want to achieve LDL-C levels at goal of less than 1.8 millimoles per liter as our primary goal of therapy. Of course, statin therapy should be added to lifestyle regardless of the baseline lipid levels for all patients with type 2 diabetes who have pre-existing cardiovascular disease, includes ischemic heart disease, cerebrovascular disease, or peripheral artery disease. So like I told you before, angina, MI, stroke, TIA, and of course peripheral artery disease. Have chronic kidney disease, that's an EGFR of less than 60 ml per minute per 1.73 square meters, are older than the age of 40 years, or alternatively have diabetes for more than 10 years with one or more cardiovascular risk factors, and that includes, of course, hypertension, smoking, low HDL-C levels, and a family history of premature cardiovascular disease or any kind of albuminuria or chronic kidney disease, which we've already discussed above. The other one that's not mentioned here is cigarette. Oh, it is mentioned here, cigarette smoking. I just didn't see it. Right. And obesity is not mentioned here, which is definitely one that you must take into account. Monitor the LDL-C 3 months after starting therapy, right? And when you monitor the LDL-C 3 months after starting therapy, you can just look specifically at the LDL-C levels. You don't need to get a whole lipogram. The person then doesn't need to fast, of course, for that. And therapy should be adjusted annually once the target is reached. Alright, overweight and obesity, I think you've discussed quite a bit in your STEPS lecture, so I'm not going to go into too much of detail regarding it. Just to remind you that overweight and obesity increases the risk of developing coronary artery disease, hypertension, and dyslipidemia. It also increases the risk of developing diabetes or worsening the patient's diabetes as well. A higher BMI means a greater risk for coronary artery disease. At every patient's encounter, you should of course measure their weight and their height, and you should calculate their BMI. And the patient's waist circumference should always be measured as well, as waist circumference is a greater predictor for cardiovascular disease compared to BMI, particularly if the BMI is less than 35 kilograms per square meter. Right, the consequences for obesity you already know. You know, for example, that it increases the risk for type 2 diabetes. It also increases the risk for steatohepatitis, non-alcoholic fatty liver disease, cirrhosis of the liver, coronary artery disease, congestive heart failure, stroke, chronic kidney disease, hypertension, whether systemic or pulmonary, obstructive sleep apnea, which can worsen hypertension incidentally, osteoarthritis, and of course gastroesophageal reflux disease, Barrett's esophagus, and of course esophageal adenocarcinomas as well. We also know that there are two different types of obesity, android and gynoid obesity. Android obesity is generally apple-shaped obesity, where there is predominantly fat accumulation in the truncal area, and this is visceral adiposity, and it increases the risk of cardiovascular disease. It's more common in men. It causes a higher odds of increased blood pressure, higher odds of increased blood glucose, and higher odds of increased triglyceride levels. And we know, particularly in diabetic patients, if we have all of these, we've got a trifecta of problems, because not only are they at increased risk of cardiovascular disease, we know that blood pressure is a cardiovascular risk factor. We know that if their blood sugar is uncontrolled, it's a cardiovascular risk factor. We know if their triglycerides are uncontrolled, it's a risk factor for acute pancreatitis. And of course, there's increased risk of breast cancer in women with android obesity, and an increased risk of obstructive sleep apnea in women with android obesity. And of course, if women have android obesity, there's an increased risk of polycystic ovarian syndrome. Additionally, gynoid obesity, which is pear-shaped obesity, is far more common in postmenopausal women. It is truncal adiposity. There is accumulation of fat in the glutofemoral region, right there, as opposed to the accumulation of fat in the truncal areas, which is here, right? And of course, it has a lower odds of increased blood glucose, a lower odds of increased blood pressure and triglycerides, and has not been concretely linked to cardiovascular disease. Right, which is why I think it's worth noting that you must take into account the type of obesity that the patient has as well. Now, ethnicity also needs to be taken into account, and this is according to the International Diabetes Forum, right? International Diabetes Federation, excuse me. And the BMI for Asians, as you are well aware, is 2.5 kilograms per square meter lower than that of any other population, and that is primarily because of the YY paradox. And the YY paradox refers to Yajnik and Yudkin, right, which I'm sure you are aware of. Both of them were actual medical scientists. One was a physician and the other one was a more medical scientist and less of a physician, but one was an athlete and one was an emergency room physician. And of course, both of them were extremely active people. They both had the same BMI, but when they did a DEXA scan of the abdomen, they found that Yajnik, right, who was of South Asian descent or Asian descent, had much more intra-abdominal fat accumulation, even though his BMI was exactly the same as Yudkin, who was of Euro-Rapid descent, which is why we say that you must take into account ethnicity. And you must take into account ethnicity as well when you are doing waist circumference measurements. And we know that in the sub-Saharan African population, right, men must have a waist circumference of less than 94 centimeters. In the Euro-Rapid population, less than 94 centimeters. The Asian population, less than 90 centimeters. And of course, the Chinese population, less than 85 centimeters. And for all women, their waist circumference should ideally be less than 80 centimeters, because this will then result in a lower risk of cardiovascular disease. Now, for overweight and obesity, the only thing that we can do is weight loss, right? And remember that we are ideally looking for a 5 to 10% weight loss from baseline over a 6 to 12 month period. Remember that a 5% reduction in weight will result in a 3 and 2 millimeter reduction in systolic and diastolic blood pressure respectively, and a 5 to 8 kilogram weight loss will result in a reduction in LDL-C, a reduction in triglycerides, and of course an increase in HDL-C levels. So you can get an increase in HDL-C levels by reducing a patient's weight, by stopping them from smoking, and of course by increasing the exercise levels. And to actually reduce weight, we need to use a calorie restricted diet of approximately 12 to 1500 kilocalories per day in females and 15 to 1800 kilocalories per day in males. Of course, diet and exercise should be used for weight loss, and we should refer the patient to the dietitian for an optimal diet plan that takes into account their current lifestyle. Of course, it's worth noting that intensive lifestyle intervention in diabetes with cardiovascular risk was compared to standard lifestyle intervention in the Look Ahead trial, and this resulted in a 5 to 10% weight loss in the intensive lifestyle intervention group, but not a reduction in cardiovascular disease. But it did reduce blood glucose levels, which means these patients then required less, and this is very important, they required less type 2 diabetes medication to control their diabetes. Right? They required less medication to control their blood sugar levels, which is important and worth noting. Of course, therapy is indicated only for motivated individuals, those who are motivated to lose weight, and depending of course on their BMI, different therapies are indicated or not indicated. For example, diet, lifestyle, and physical activity and behavior therapy are indicated across all BMI ranges, right? But pharmacotherapy is only indicated from the BMI of 27 upwards for all BMI ranges thereafter, and bariatric surgery is only indicated from either 30 kilograms per square meter upwards in non-Asians and 27.5 kilograms per square meter and upwards in the Asian population. The pharmacotherapy of choice includes either liraglutide, phentermine and topiramate, or orlistat. Long-term use of these drugs is not advised, and they should be discontinued if 5% of weight is not lost within a 3-month period. Right. Phentermine and topiramate. Now, with all of these drugs, you must look specifically at their placebo, at their average weight loss relative to the placebo, and the percentage of patients who achieve greater than or equal to 5% weight loss from baseline. And we can see based on this that the agents that we would most likely use are either phentermine and topiramate or alternatively liraglutide. Phentermine and topiramate will of course cause 8.8 kilograms to be lost relative to the placebo, so that's the placebo subtracted weight loss as we sometimes refer to it as, and approximately 45 to 70% of patients will achieve their weight loss goals. Now, paresthesia, xerostomia, constipation and headaches are all common adverse effects, and remember that topiramate is teratogenic and leads to cleft lip palates in children, in fetuses, excuse me. Right, now liraglutide, as we've already discussed before, and it's worth noting again that Liraglutide is one of those agents that we use in diabetic patients who are obese or overweight to help them to lose weight, and it's one of the more compelling indications. The other compelling indication, as we'll come to later, based on the based on the LEADER trial, right, which most of you know about, is that we use them for patients with pre-existing cardiovascular disease or severe cardiovascular disease to reduce their cardiovascular outcomes. Right? And you'll notice that the dose here is slightly higher. For liraglutide, you may have to go up to 3 milligrams subcutaneous daily. I think that this particular dose is more impactful for patients who are not diabetic. In diabetic patients, you shouldn't exceed the 1.8 milligrams per day. Remember that when combined with other agents, it can cause hypoglycemia, nausea, vomiting, and diarrhea are very common, and to reduce this, we would suggest the patient uses liraglutide at night. Constipation can occur, and as we discussed in the previous lecture, right, diabetic gastroparesis. If the person has diabetic gastroparesis, which is a form of diabetic autonomic neuropathy, you may need to stop glucagon 1 receptor analogs like liraglutide, for example, particularly if their symptom of gastroparesis tends to be constipation. It may also cause headaches. We know that liraglutide does in some cases cause pancreatitis, and T-cell carcinomas have only been proven in rats and have yet to be proven in humans. And if anyone was actually reading their LEADER trial really well, and since you did an assignment on this, I'm assuming you went through in significant detail the LEADER trial itself, right? You would have probably noticed or have noted, right, that T-cell carcinoma in the LEADER trial wasn't any more common in those patients using liraglutide as compared to the placebo. Worth noting, isn't it? Right. So patients who self-select, in other words, they choose by themselves, right, for a healthy diet, right, tend to have a reduced risk for coronary artery disease. Observational studies have suggested that the Mediterranean diet reduces cardiovascular disease, but the truth is that overweight and obese patients can use the Mediterranean diet, the low glycemic index diet, the low glycemic load diet, or even the energy restricted low fat diet. All of these will reduce their weight, but will also reduce their risk of cardiovascular disease. And the important components of a healthy diet include fruit and vegetables, high fiber intake, food with a low glycemic index or low glycemic load, monounsaturated fatty acids, and omega-3 fatty acids from dietary sources, especially fish. We know that there is an inverse relationship between exercise and cardiovascular disease. That means that if there's decreased exercise or physical activity, there's an increased risk of cardiovascular disease, and vice versa. If there is an increased risk of increased exercise, there's a decreased risk of cardiovascular disease. And meta-analyses have demonstrated that there is a decreased risk of coronary artery disease and stroke in patients who are physically active. We also know about the guidelines regarding physical activity. We know that adults should perform approximately 150 minutes of moderate intensity exercise per week and not skip or not have more than 2 days in between their moderate intensity exercise. Not have more than 2 days in between where they do not do moderate intensity exercise, rather. And examples of such moderate intensity exercise includes brisk walking, swimming, and cycling. An alternative to this is the performance of 75 minutes of vigorous intensity exercise, right, where they achieve much higher heart rates. In overweight and obese patients, the recommendation of 2.5 hours per week is used to produce weight loss, but higher levels of 3 to 5 hours per week are recommended for weight maintenance, right? And moderate physical activity such as brisk walking for 20 minutes a day is still associated with significant benefits in reducing coronary artery disease. And this always brings me back to the point that I make to a lot of people. It's like, you just need to tell them, right, even if you're only going to do 20 minutes once a week, that's a start. It's a start, and then you build on that. And this is something that's worth noticing. If somebody goes from doing no exercise to doing exercise once a week, that's 100% increase from baseline. And then if they go from doing exercise once a week to doing exercise twice per week, then that's 100% increase from the once a week. But it's a 200% increase from baseline. And if over 1 year they go from doing exercise once per week to 5 times per week, you've got a 500% increase from baseline. Right? So imagine the effect that you're having just by suggesting to the person, try once a week for a couple of weeks. And then when you come back and I see you again for your next appointment for your diabetes, or alternatively, when I see you for your next prescription, maybe then we'll discuss, okay, how's the once a week going? Oh, the once a week is going really well. Okay, come on. Let's see, maybe we can do twice a week. And we try that. Right, hypertension. Systemic hypertension is extremely common in patients with type 2 diabetes, and in fact, patients with type 2 diabetes have a higher risk of developing hypertension when compared to non-diabetics. And of course, hypertension will affect the majority of patients at some point during the course of their disease. And of course, diabetics are also at higher risk for hypertension-mediated organ damage, such as damage to the eyes in terms of hypertensive retinopathy, diabetic damage to the kidneys in terms of course, hypertensive damage to the kidneys in terms of chronic kidney disease, and even hypertensive-mediated damage to the heart in terms of left ventricular failure as well. Hypertension is an important modifiable risk factor in both macro and microvascular complications. And as we discussed in the microvascular complications lectures, and you will remember, we always said every time we were discussing, particularly when we were discussing diabetic eye disease and diabetic kidney disease, we must control the blood pressure. Right? Blood pressure must be measured at every clinic visit. So of course you know how to measure blood pressure. Right? You know, for example, that you should be measuring blood pressure where the person is seated for at least 5 minutes. Their arm must be resting at the level of the heart. You must use the appropriate size cuff where the index must lie within the range line. We know that the artery marker must pass over the brachial artery itself. We know that we must estimate the systolic blood pressure by palpating the radial artery, for example, and then slowly pumping up the cuff to 30 millimeters of mercury higher than where the radial pulse has actually disappeared, then opening the cuff completely, then using either the diaphragm or the bell of the stethoscope. If you're using the diaphragm, you're going to put it directly over the antecubital fossa itself. Alternatively, if we're going to use the bell, you're going to put the bell directly over the brachial artery, and remember not, of course, to occlude the brachial artery. Remember that the placement of the cuff must be 2.5 centimeters above the antecubital fossa, or 2 finger space above the antecubital fossa, and no more than 2 finger space must actually go underneath, etc., etc. You are all experts at taking blood pressure at this point, so I don't need to repeat myself and to tell you the entire process from scratch. Right. The diagnosis of hypertension. Systolic blood pressure must be greater than or equal to 140 millimeters of mercury, and diastolic blood pressure must be greater than or equal to 90 millimeters of mercury. In a clinic setting, this must be done on 2 separate occasions. Ambulatory blood pressure may not always be available to confirm the diagnosis, but we know that it is the most ideal thing to confirm the diagnosis, right? And compelling indications for ambulatory blood pressure include when somebody has suspected white coat hypertension. In other words, they don't have overt hypertension, but they may have what we call hypertensive mediated organ damage, and you may think, this doesn't make sense to me. Sorry. You have suspected white coat hypertension in that the patient themselves, I'm confusing concepts here, which is very bad actually. Let me start again so that I don't make this mistake. Right. Suspected white coat hypertension is where the patient's blood pressure tests high at the clinic, but at home it doesn't test high at all. You use the ambulatory blood pressure monitor to notice what their blood pressure is at home. Hypertension that is resistant to increasing medication, right? That's another one. Hypotensive symptoms while taking antihypertensive medication, right? Autonomic dysfunction, right? And of course, suspected episodic hypertension in the form of pheochromocytoma. Another one is where a person has what we would consider in some scenarios to be high normal blood pressure, right? But you find that they have hypertensive mediated organ damage like hypertensive retinopathy or kidney disease. In those scenarios, then you would also use ambulatory blood pressure monitoring. Systolic blood pressure targets for most patients is somewhere between 130 and 140 millimeters of mercury. Roughly we say 130 to 139, and the diastolic blood pressure must be 80 to 89. And systolic blood pressure treatment targets for those at higher risk of stroke, right, should be below 130 millimeters per mercury if this doesn't cause undue treatment burden. And meta-analyses suggest that patients with hypertension benefit from pharmacotherapy if their systolic blood pressure is greater than or equal to 140 millimeters of mercury, and this is particularly true in diabetic patients. Lifestyle interventions you know all about. There needs to be some kind of weight reduction. You need to consider the DASH diet. There must be no more than 6 grams of salt taken per day, of table salt that is. There must be an increase in physical activity. They must moderate their alcohol consumption, and of course there must be a complete cessation of smoking. Although that doesn't lead to a decrease in systolic blood pressure, it actually reduces their cardiovascular risk. Now, in terms of the pharmacotherapy of hypertension, all classes of antihypertensives are effective in reducing all-cause and cardiovascular mortality. The combination of ACEs and ARBs are not recommended because they increase the risk of hyperkalemia, as we suggested previously, and they can also lead to kidney failure as well. The preferred agent, of course, in terms of diuretics is indapamide 2.5 milligrams per day, and this is a dose you must know. And of course, when there is no albuminuria, you can of course consider ACEs, ARBs, thiazide diuretics, or calcium channel blockers as the first choice. ACEs have been shown to reduce major cardiovascular events in diabetic patients, and we know this based on the trial data that we have. Meta-analyses comparisons of ACEs and ARBs in terms of cardiovascular outcomes in hypertensive patients with type 2 diabetes. We notice that ACE inhibitors not only reduce all-cause mortality, they also reduce cardiovascular death, they reduce MIs, they reduce strokes, right? They also reduce heart failure, and they reduce all cardiovascular events. And all these 95% confidence intervals and of course the p-values are all significant, and the relative risk reduction ranges anywhere between 13 and of course 35%, which is massive, right? ARBs, on the other hand, are not very good at reducing any one of these. They don't reduce any type of all-cause mortality. They don't reduce cardiovascular death. They don't even reduce the risk of MIs, strokes, heart failure, or cardiovascular events. Right, when it comes to renal and CV protection in terms of antihypertensive medication, the best there is a combination of perindopril and indapamide. So that's the advanced trial that was looked at there, and they enrolled over 11,000 patients there. So there you get dual renal and CV protection, right, compared to the placebo. So here you can look at either using perindopril 4 milligrams combined with indapamide 1.25 milligrams, or perindopril 5 milligrams combined with indapamide 2.5 milligrams, or you can go to a lower dose one if required, which will be perindopril 2 milligrams and indapamide 0.625 milligrams, which is called Pretirex. The advanced trial says that the total renal events in terms of either worsening worsening nephropathy, or new onset microalbuminuria were all reduced using the combination of perindopril and indapamide. And of course, there was a significant mortality benefit in terms of cardiovascular mortality, with an 18% relative risk reduction with the combination of perindopril and indapamide versus the placebo, which was only a 14% relative risk reduction. Now, this slide here tells you that when treating diabetic patients, particularly, the best combination seems to be an ACE inhibitor and a diuretic. It's worth, however, noting that if the person is intolerant to an ACE inhibitor and a diuretic, remember the preferred diuretic here is indapamide, right? And we half the dose of the indapamide in that scenario, right? So then if the person is intolerant to the ACE inhibitors such as perindopril plus indapamide, we then need to use an ARB plus hydrochlorothiazide as the choice diuretic there. It's also worth noting that depending on the patient's circumstance, you may need to add on other medications to control their blood pressure. So for example, you may need a long-acting calcium channel blocker in those patients with angina. Those with a previous MI will require the combination of a non-selective beta blocker and an ACE inhibitor. Now, I know you're going to say, but that may mask hypoglycemia, and that may be true. But unfortunately here, you want to prevent sympathetic remodeling of the heart. So that's why you should do this. Then where there are other alternatives, of course, you'll go with the other alternatives. Of course, you must take into account the compelling contraindications as well. So, for example, diuretics, we cannot give them to patients who have gout, for example. You'll notice that glucose intolerance is a possible contraindication, but we still use the diuretics. We just use them at lower doses in diabetic patients. Beta blockers should not be used in asthmatic patients or those with any high-grade SA and AV nodal block or any kind of bradycardia, for example. Right? You'll notice that glucose intolerance is listed as a possible contraindication here as well. When it comes to the standard calcium channel blockers, the dihydropyridones, such as, of course, nifedipine and amlodipine, there's no compelling contraindications as such. Relative contraindications include heart failure, depending on the class of the heart failure and whether it's heart failure with reduced ejection fraction or not. And of course, pre-existing or severe edema, and of course tachycardia. Verapamil and teldiazem are completely contraindicated in left ventricular dysfunction, in bradycardia, and any high-grade SA or AV nodal block. ACE inhibitors should not be used in pregnancy, patients with bilateral renal artery stenosis, patients with previous angionecrotic edema, and of course patients with severe hyperkalemia. Patients taking ARBs are contraindicated in pregnancy, in hyperkalemia, and in bilateral renal artery stenosis. So, a reminder again with regards to blood pressure management. Blood pressure should be measured at every routine visit, and patients found to have elevated blood pressure should have their blood pressure confirmed on a separate day. Threshold for initiating blood pressure in type 2 diabetes is greater than or equal to 140/90, and of course you want to achieve a blood pressure goal of roughly between 130 and 139, and a diastolic blood pressure goal of 80 to 89. Systolic blood pressure treatment targets for patients for high risk, such as those who are at high risk of having stroke, should potentially be less than 130 millimoles. Less than 130 millimeters of mercury, and this should be achieved without any undue treatment burden. If there is undue treatment burden, it should be avoided. Lifestyle modifications including weight loss, reducing salt intake, moderation of alcohol intake, increasing physical activity, decreasing smoking should all be emphasized. All classes of hypertensive agents are equally efficient in reducing cardiovascular disease and complications. But the ideal combination should be the combination of an ACE inhibitor with either a diuretic or alternatively an ARB with a diuretic if an ACE inhibitor cannot be used, such as in anginecrotic edema or in severe dry cough. The combination of the ACE or the ARB is not recommended at any level, including the primary care level. In patients with type 2 diabetes and hypertension, indapamide is the thiazide diuretic of choice. If you're just going to use indapamide by itself, you're then going to use a dose of 2.5 milligrams per day. If you're going to combine it with another medicine, like for example an ACE inhibitor, you then may start off at 1.25 milligrams per day. You may have to increase if necessary. Remember, the ideal choice based on the advanced trial is perindopril and indapamide, either perindopril 4 milligrams per day with indapamide 1.25 milligrams per day, or perindopril 5 milligrams per day with indapamide 1.25 milligrams per day. And of course, as a half dose, you could use Pretirex, which is perindopril 2 milligrams per day, and indapamide 0.625 milligrams per day. We can, however, use ARBs, thiazide-like diuretics, or calcium channel blockers as the first choice as monotherapy in most patients. Remember that the first choice of monotherapy in patients with microalbuminuria is either the ACE or the ARB, depending on the severity. The compelling indications for drug classes. The following drug classes have been shown to be of benefit in diabetic kidney disease. That includes ACEs, ARBs, and we can in some cases use thiazide-like diuretics like indapamide, or non-dihydropyridone calcium channel blockers like verapamil and diltiazem. For patients with heart failures, we want to use either ACE and ARBs. Calcium channel blockers are not recommended. For those at high risk of stroke, such as those with a history of previous cerebral ischemia, significant carotid stenosis, uncontrolled hypertension, calcium channel blockers are therefore recommended, and beta blockers should be avoided, right? And for patients with coronary artery disease, beta blockers are indicated. So we know that blood sugar goals should be negotiated with the patient and their primary care provider. But what indicates control? And I think that this is an important question to ask. How do we measure control, and what is the general concept behind this? Well, what indicates control is the patient's HbA1c level. And how do we measure it? We measure the HbA1c. And what essentially is this concept? The concept of HbA1c is the number of glucose molecules that are actually attached to the hemoglobin molecule itself. Right? The higher the percentage of glucose molecules attached to the hemoglobin, it means that there is a large amount of glucose circulating in the blood, and it therefore means that the person's blood glucose levels are uncontrolled. So you need to take into account, is the patient's HbA1c level less than 6.5%, less than 7%, less than 7.5%? And then the patient must have a good diabetes management plan. Now, we've already discussed how we take into account and how we decide what their person's diabetic goal is. When you're talking about the blood sugar management goal, it's very, 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 very important that you negotiate the goal with the patient. You say, this is what we'd like to achieve. How can we go about achieving this? When you make this a shared responsibility between yourself and the patient is when you are more likely to get the response that you are looking for. Dietary and exercise plans must be included as well. Remember that there is no one size fits all approach, and and you must not forget the importance of pharmacotherapy. Now, right. What is the goal of the patient that they can measure on a day-to-day basis? The goal that a patient could measure on the day-to-day basis is, of course, their blood glucose levels. And how do we measure it? Well, if we know that For all of the HbA1c goals, we want to target a fasting plasma glucose level or blood glucose level of between 4 to 7 millimoles per liter. That's upon awakening after approximately at least an 8 hours worth of fasting. And then their postprandial blood glucose levels, that's 2 hours after they eat, right, is very dependent on what the A1C goal is. If the A1C goal is less than 6.5, you want a postprandial blood glucose level of less than 8. If the A1C goal is less than 7, you want a postprandial blood glucose level of less than 10. If the A1C goal is less than 8 or less than 7.5, depending on the scenario, this will particularly be important for older patients, those with a shorter lifespan, those with a higher risk of hypoglycemia. Then you want to target a postprandial blood glucose level of less than 12. Remember that for every 1% reduction that a patient achieves in the HbA1c level, they reduce their risk of cardiovascular disease related deaths by 21% and heart attacks over 10 years by 14%. And this shows us the importance of reducing glycated hemoglobin levels or HbA1c levels. You must of course take into account and be wary of hypoglycemia. Right, we know from both the ACCORD and the ADVANCE study, right, that as well as the VADT trial, that when you severely cause hypoglycemia with the aim to try and reduce blood glucose levels to such an extent, you actually increase their risk of cardiovascular disease, and patients end up dying of cardiac arrhythmias. So you must educate the patient on symptoms of hypoglycemia and instruct them to report hypoglycemia to their primary care providers. Lifestyle changes such as smoking cessation, dietary exercise, aerobic exercise, etc. are extremely important. A target HbA1c for reducing cardiovascular disease and microvascular complications for most patients will be less than 7% of their getting their glycated hemoglobin to less than 7% in both type 1 and type 2 diabetes. But this of course is very dependent on the number of things that we've already discussed. I think the last thing that of course we'll next to discuss is what agents we should be using in the management of type 2 diabetes to take into account their blood glucose levels and their cardiovascular risk. So what has happened is that both the American Diabetes Association and the European associations have taken this into account, and they've come up with this particular treatment algorithm. And in the treatment algorithm, you generally start off with this, giving the patient metformin as your first agent that you use, and then after that you take into account whether they have atherosclerotic cardiovascular disease which predominates, or they have heart failure or chronic kidney disease which predominates. And if they have atherosclerotic cardiovascular disease, we will prescribe a glucagon 1 receptor analog with cardiovascular benefit. So in this case, in South Africa, we will use liraglutide. Alternatively, you can use an SGLT2 inhibitor with cardiovascular benefit. So either then we're going to use empagliflozin or canagliflozin as our 2. And then we'll then redo the HbA1c. If the HbA1c is above target, right, we will then add on either a glucagon 1 receptor analog or an SGLT2 inhibitor. If you've added the glucagon 1 receptor analog, you'll then add on the SGLT2 inhibitor or vice versa. And then you'll consider adding on other agents depending on the need, if the need is required to achieve the HbA1c after that. If of course heart failure or chronic kidney disease predominates, there we want to primarily use our SGLT2 inhibitors, because we know that SGLT2 inhibitors have mortality benefits in heart failure, and they also have benefits that are found in chronic kidney disease, which we already discussed in our microvascular complications lecture. So you can go through and have a look at those. And then after that, we then add on any other anti-diabetic agent as required. We may have to add on DPP4 inhibitors and other agents as required. But we must take into account their cardiovascular risk, and if their cardiovascular risk is high, we may then even consider the use of GLP-1 analogs. The GLP-1 analogs with cardiovascular benefit, and the two that we know of are, of course, liraglutide and semaglutide. I'm going to ask you to remember the dose of liraglutide, obviously. Right. When it comes to aspirin in primary prevention, we know that aspirin is currently not recommended in primary prevention of cardiovascular disease in diabetic patients, but it is strongly recommended in secondary prevention. That means in somebody who has previously had a heart attack, stroke, MI, etc., TIA, peripheral artery disease, angina, etc. The optimal dose of aspirin for secondary prevention is not known. Anywhere between 75 and 162 milligrams per day of regular aspirin is fine. Patients with established cardiovascular disease who are intolerant to aspirin must use an alternative platelet aggregation inhibitor. And here I'm going to ask you to remember one important drug here, which is clopidogrel at a dose of 75 milligrams per day. Improved vascular protection is more effectively achieved with the inhibition of the renin-angiotensin-aldosterone system and lipid modifying therapy. In other words, better vascular protection is actually where you use statin therapy and ACE inhibitors or ARBs. Right. If you have any questions, remember you can always email me and I will get back to you with an answer. If you come across any mistakes that I've made, please feel free to email me and question me about it. And I'll either correct the mistake so that everybody knows I've made the mistake, etc. Thank you very much for your time. And we've come to the end of our diabetes lecture set. From here on in, we're going to go on to other endocrine disorders. We're going to discuss the hypothalamus and pituitary. We're going to discuss the adrenal disorders. We're going to discuss the thyroid disorders, the hypothyroid disorders, and lastly, we're going to have a section on osteoporosis.